My guest today has not only changed the lives of many, he's saved the lives of many. Today, I'm joined by Dr. JFM, who's a world-renowned neurosurgeon and professor of neurosurgery at Stanford University School of Medicine. He is internationally recognized for his expertise in pituitary and skull-based surgery with a particular focus on advanced endoscopic and minimally invasive techniques. I'm thankful that Dr. JFM has dedicated his career to improving outcomes for patients with complex pituitary disorders, including acromegaly, through surgical innovation, research, and education. He's a leader in neuroautonomy and surgical training, having taught surgeons around the world and published extensively in peer-reviewed medical journals. Known for combining technical excellence with compassionate patient care, Dr. JFM is committed to helping patients not only survive surgery, but truly regain a high quality of life. Dr. JFM, I'm excited to have you here. Welcome to Talking Acromegaly with Tony.
Tony, thank you very much for your kind introduction. It is my pleasure, my honor to be here with you, hoping to help our community of acromegaly patients, dealing with the disease and making the right decisions.
Thank you. Thank you. I appreciate that. Let's get into patients making the right decisions. You are a neurosurgeon that takes on very complex surgeries. You take on surgeries that other surgeons turn down or may say no to. What makes you say no to a surgery, and why do you take on the more complex surgeries?
Well, what makes me to say no to an operation, it is when I think I'm not going to be able to help that patient, and the chances of, hurting that patient or not helping that patient are significantly higher than the chances of helping them. So when I don't think there is a good chance for success, then I don't recommend an operation. On the other hand, if I believe I can help, I believe an operation can be of significant benefit to that patient, even though that operation can have some risks. If I think the risks are worthy, from my perspective, then I would recommend an operation, even though maybe that patient had previous operations that failed, even though many other surgeons perhaps said that operation is not worthy or too risky. I might disagree because we have sometimes more advanced knowledge, skills, techniques, and sometimes I can help when others could not. But of course, it's not always the case. Sometimes I have to say no.
Understood. How would you define a successful outcome or a successful surgery when a patient still needs ongoing treatment or monitoring?
Sorry, would you mind repeating the question because it cut off for a second?
How do you define a successful outcome or when a patient still needs ongoing treatment or monitoring?
Well, successful outcome in acromegaly has objective and subjective measures, I would say. The objective ones are, your lab values normalizing, IgA1 levels normalizing. More subjective is how the patient is doing, how the patient is feeling. Sometimes we focus too much on the number, and patients are much more than a value in a lab number, right? So we need to focus on how the patient is doing, symptoms they are having. Typically, they go along. Typically, if your IgA1 levels are normalized, patients do feel better. And a successful operation, you can tell early on because patients have decreased swelling, they feel better, the headaches are gone, joint pain is better. There are many symptoms that patients noted immediately after the operation that are better. Some of them are unfortunately lingering, even though they're in remission clinically and biochemically in remission. Some symptoms are lingering because acromegaly, as you well know, patients will know, often has a delayed diagnosis, and patients have been suffering with acromegaly for many years before a diagnosis. So for example, joint pain might not completely improve. Some issues are still going in spite of being in remission. But the success is measured, again, on achieving biochemical remission, but also making patients feeling better and achieving that in the long term. We want to have long-term remission. And ideally, a successful operation means the patients are cured from the disease. They do not need any medication in the future. They do not need radiation. These days, we can achieve this in the majority of patients, even in the most complex tumors. 80, 90% of our patients are being in remission after an operation with us. There is still 10, 20% of patients that will need medication or will need radiation. I typically recommend radiation only in those cases where surgery has been maximized. We've done everything we can. And if there's still some residual tumor in an area that surgery is not ideal, that's when radiation has a significant role. And when you've tried everything and patients are still not in remission is when medication has the best indication to, help patients improve their symptoms and get normal lab values. But again, successful operation means you're cured. You need nothing else than that single operation.
Unfortunately, for me anyway, you didn't perform my surgery, and I really wish you would have. I am not in remission. I am on medication, and I want to talk about what a symptom or a side effect that affects me on a daily basis from the day I had surgery, which is brain fog. How common do you find that in patients after having pituitary or brain surgery?
Brain fog after surgery, I think, well, in the short term might be relatively common, especially the first weeks after an operation. I honestly would not expect the brain fog to continue after that initial healing period. If it continues, I would maybe wonder why. If it's through the operation, if it's maybe the medications, I can't tell, but it's not a common thing to have brain fog after the initial period of healing after an operation.
Okay. Well, that's something that I probably need to check more into with my primary care doctor or my endocrinologist. Maybe it's just something going on with me after 50. Let me ask you this from a
Maybe.
let me ask you this from a patient's point of view. Pituitary surgery for me and for many others was terrifying. When
Yes.
you hear someone or when you tell someone that they need brain surgery, what do you wish that they understood right away that may ease their fear?
Okay. So first I tell them, this is not brain surgery. This is pituitary surgery. I explain to them, look, the pituitary is underneath the brain. So we're not going to touch your brain. We're not going to touch your optic nerves. We're not going to go into the inside of the head. We're going to go through the nose. It's like making a trick. We're going to trick the tumor. We're going to go through the nose using the sinuses to get into the tumor. And the brain stays above. We don't even see it. So that's first thing. Second, if you're in the right hands, in the right expert surgeon doing these operations, this is a very low risk operation. The risk of something going really wrong, meaning having a major stroke after the operation, having major complications that are life-changing, is extremely low. It's below 1%. Now, that can change if you are in the hands of a less expert team, but in an expert hands team, the risk of something really bad is less than 1%. In fact, it's in the order of 0.1, 0.2%. I'm talking about the risk of injuring a carotid artery, having a stroke from that, for example, or having meningitis that is not resolved and it causes permanent brain damage. Those are the things that we fear the most and the things we're going to avoid at all cost. But again, it's extremely, extremely unlikely. Still, my obligation, my responsibility is to explain my patients that it's always that 0.1, 0.2% chance. But I think when you tell them the numbers and the odds, I think they feel reassured because it is very unlikely. Now, I also explain to them there are other things that can happen more often in the range of the 1% to 5% risk, which is you can have a CSF leak that needs to be fixed, but that's fixable. You can have some other low hormones that need to be treated transiently or permanently. So that's not ideal, but it's treatable. It's not a major thing. You can have some transient double vision, especially for those tumors that go into the cavernous sinus. And it's very rare that that's a permanent issue, and that resolves. And of course, you're going to have that's the 1.5% range. And then we have the guaranteed side effects you're going to have. You're going to go through an operation, unavoidably, you're going to feel it. You're going to feel it. You're going to feel your nasal cavity that is congested, that it needs to heal, that the nasal cavity is not the same. With a bit of luck, it will heal very well, and you will have no sequelae from that in the long term. But a few patients do have some issues in the nasal cavity in the long run even. They are minor. They don't affect your quality of life in a very significant way. But they need to understand that the nasal cavity needs to recover, and your whole body needs to recover from the operation. It takes a while to wean off from the anesthesia and recover from the burden and the effort of going to an operation like this. But overall, I try to reassure them that this is a very low risk operation in expert hands with excellent results.
That is good to hear. Those percentages that you mentioned aren't numbers or percentages that I heard when I had my surgery from my neurosurgeon in 2016. I was flat out told, don't get this wrong, Tony. This is brain surgery, which put me at a higher level of anxiety, more or less. And I delayed my surgery for a little bit longer just because the fact of how fearful I was behind having it. From what I heard from other patients and that you've dealt with and had surgery with, you've always been very thorough in explaining everything to them. And I wish that I had my doctor been as thorough as you've been. With that being said, when a patient finally lands in your office after years of symptoms, what are some of the most common questions that they ask or should be asking that other patients who are needing this surgery in the future can keep a record and jot down?
Well, I think patients need to ask, generally speaking, when they meet with a surgeon, the first need to go to what they need to understand whether the surgeon is an expert or not. And you can understand that rather quickly by talking with other patients, talking with endocrinologists, talking with other surgeons. Is your surgeon one that other surgeons would refer patients to, or other endocrinologists would refer patients to? Is your surgeon one that is fully dedicated to pituitary surgery or to pituitary and skull-based surgery? Is that his or her occupation 90% plus of the time? Is that all you do? Or is your surgeon one that is doing multiple things at the same time, doing spine surgery, doing brain tumors, doing pituitary tumors? How many tumors is your surgeon doing a year? Pituitary tumors specifically. And of those, how many of those are complex tumors or not, or just straightforward versus complex tumors? Is your surgeon comfortable going to the cavernous sinus and versed in the newest techniques? One of the things we found out over the last decade is that specifically growth hormone adenomas, tumors that cause acromegaly, invade the cavernous sinus very, very often, much more often than expected. About 80% of the patients do have some degree of invasion of the cavernous sinus. We describe how this membrane, there is a membrane that separates the pituitary gland from the carotid artery. We call this the medial wall of the cavernous sinus. That membrane is invaded to some extent in about 80% of the patients. That is incredible high. And before it was said it was maybe about 30%. But we found that many patients do have some invasion of that wall. Some of them do have frank invasion through the wall into the cavernous sinus, making things much more difficult. So how comfortable is your surgeon doing resection of that wall or working inside the cavernous sinus to remove that tumor? To the point that until recently, and still today, you can hear surgeons or endocrinologists recommending against going to the cavernous sinus to remove tumor. And I think that's a prudent thing to do and say if you don't have the expertise. But today we have the ability and the techniques to do this safely with excellent results. And we are, documenting this and publishing our results. You mentioned before how valuable is to talk about numbers and specifically range or percentages. We do this because we collect extensively our results prospectively. We look at them retrospectively to evaluate how we did, and we collect them prospectively to have accurate registration of information. So I can tell a patient that comes to my office, one of the last 100 cases that we've done here at Stanford over the last X years, these are our results. 5% of this, 1% of this, remission rate is 90%, et cetera, et cetera. All documented on our own numbers, not numbers from someone else. Now, it's true that you can go to another surgeon's office and they maybe quote my numbers or someone else's numbers. So from the literature, that is not that accurate. You need to quote your own numbers, ideally, based on your own expertise. Questions that patients need to ask are, it depends on the knowledge of the patient and how much information patients want to get. And I found a whole range. Patients are very different. We are all different. Some patients do want to know specifically all the details of the surgery, even the technical details. I also treat a large community here in Maine, in Silicon Valley, of engineers, for example. Engineers want to know how everything works. So you need to explain them in detail what you're going to do. Some other patients don't know much detail about it. They don't really care. They just trust you. I think the trust in your surgeon is extremely important. You want to make sure that who is taking care of you is someone that is just not knowledgeable, but trustable. Someone you can put your life on their hands, and he knows he's going to do what is in your best interest. And that is extremely important. You need to be very competent, and at the same time, you need to have compassion. Both need to go together. One alone, you can be very competent, but you don't have compassion, that is not good. You have compassion, that's nice, but if you are not competent with compassion, that's not useful. So you need to have both to make the best for your patients. And so your patients need to find such surgeon.
Sounds good. And let me ask you this from a neurosurgeon's viewpoint. What signs make you say this patient needs surgery right now versus continue medical management and medication?
Well, if right now means urgently, that's rare. It's only in the situation where a patient is having what is called apoplexy, which means that there is bleeding within the tumor, or there is a swelling inside the tumor, and then there's acute visual loss or acute double vision or closing of one eye. That needs to be treated early, within the next 24 hours, ideally. That's a rare situation. Now, when to recommend surgery? In the near future, in the next few weeks or few months, as opposed to continue medical treatment. Generally speaking, acromegaly caused by a pituitary tumor is a surgical disease, and the primary treatment is surgery. There are very few exceptions where medication should be tried first. And the few exceptions are perhaps tumors that are very, very invasive. And we know that an operation upfront will have very low chance for remission or zero chance. In that case, try medication first. It is an option. Also, you have a patient that is very sick from acromegaly. Some patients can be so sick that they have a very narrow airway. They have very severe symptoms. Maybe you can try medication first to make those symptoms a bit better and put the patient in a better medical condition in preparation for surgery. That is a minority. I would say on our patients, less than 5% would recommend medication first. Probably less than 1 or 2%, I would say. Now, when a patient, so again, surgery is the first treatment for acromegaly, with very few exceptions. Now, when a patient already had an operation and now, unfortunately, is not in remission and medication is continued or restarted, when to do surgery in that situation is a bit more nuanced. And I think it depends on a number of factors. Number one factor is there an obvious tumor on the MRI I can see? If there is an obvious tumor on the MRI I can see, and there is a target I can go for, and I remove the tumor, and I think there is a good chance that an operation will be curative, then that's what a very important consideration versus a tumor that either I cannot see, I don't know where the tumor is. Sometimes that happens, rarely, but it can happen. Or the tumor is too invasive in an area that really is risky, then I may recommend radiation as opposed to medication or surgery. So all results for redo acromegaly, for reoperations in patients that had a previous operation, are actually very good. Our remission rate are not as good as the first operation, which is around the 90% range or 90, 92%. In reoperations in the 80% range. It's still very good. We can probably
Yes.
get in remission 4 out of 5 patients we reoperate. These are typically patients that have been operated not by myself, but by somewhere else. Typically, but other surgeons that are were not versed into going to the cavernous sinus, removing the medial wall, because that's where most often the residual disease is located. Again, in those patients, if I think I can remove the tumor entirely and get them in remission, I recommend surgery. The caveat is, if those patients are doing very well on medication, they have no side effects from medication, they are well controlled, they are not symptomatic, then I say, well, this is absolutely your choice. You're doing okay on the medication, we can wait. But we find that many patients are not doing that great on the medication. There are side effects. Set aside the cost of the medical treatment and the inconvenience of it. But I think the most important thing is, one, do we have a clear tumor that we can remove on the MRI? We can identify the MRI, we can remove that relatively safely. And two, how is the patient doing with the current management? If he's not doing great, then we recommend surgery. And again, we achieve high rates of success. We work, I know you had Jill Sisko in your podcast recently. She's been a tremendous partner in their journey. There are many patients that are in search for a curative solution if possible. And I must say, endocrinology, like surgeons, endocrinologists have different levels of expertise, different incentives. So there are many endocrinologists that are not recommending surgery for their patients, when I personally think surgery would be the best option. And I argue with them when we are in our international meetings and venues. No, at the same time, there are other endocrinologists that are wonderful. They are extraordinary partners. They know the great benefit that surgery has in their patients. They know that when surgery is done the proper way, is the best for the patients, because you can get them in long-term curative remission.
Okay, let me ask you this. From a patient perspective, remission can feel confusing.
Yes.
Their labs may improve, but sometimes the symptoms linger. Why doesn't remission always mean someone just instantly feels better?
Yeah, that is a very important topic. As we said before, acromegaly is often diagnosed late, and patients had suffered from high levels of growth hormone IGF-1 in their bodies for many years. That has an impact in your overall health that doesn't return to normal right after an operation that rapidly. Now, many things improve a lot, but some others don't. The classical example is joint pain. If you had some changes in your joints for years, they might get better. The soft tissue swelling gets better, but some of the bony changes or cartilaginous changes don't really improve that much, so that they continue having symptoms and other issues like that. That being said, being in remission should make a difference in many things, but of course, not all of them, because of the long lingering effects of acromegaly in your overall health.
Understood. So moving forward, surgeons often are seen as purely technical, yet you work with patients whose lives have been changed physically and emotionally. How do you approach the human side of the disease?
Well, what I do, and I've dedicated my life to be the best possible surgeon. And there are two reasons for that. One, perhaps less important reason, which is I love what I do, and the technical aspect and the intellectual aspect of what I do is very stimulating. But the major factor is that we're doing this for a purpose. The purpose is helping patients. Otherwise, there is no meaning on what we're doing. The whole point is to help other patients. And uh, there is no greater joy in life than seeing that your actions have a positive impact in other patients, in people in general, whatever you do in your life, right? And I'm fortunate to be a surgeon and being able to help patients with my hands and with my brain, making decisions and making actions that help patients, and it's so gratifying to see patients, being impacted by what we do. And honestly, sometimes life-changing operations that really turn around their life, and they are so happy and so thankful. So it is an immense pleasure, and it's just the joy of helping others.
You talked about making a positive impact. The fact that I'm here and doing this podcast, I wanted to make a positive impact. I wanted to share my story and help people who've gone through what I've gone through with acromegaly and help them to deal with it better. If you could speak directly to someone newly diagnosed with acromegaly, what would you want them to know from day one?
Well, I think they should know that they're not alone. First, there is a community of patients that we mentioned, Jill's before, that you can reach out. There is nothing more comforting for a patient than talking to other patients that they have experienced the same disease, the same issues. I can do my best to understand a patient, but a patient understands another patient the best, I would say. You know, I didn't mention, but I do have a little personal relationship with acromegaly in general. My wife's grandmother had acromegaly, and she lived with it, and she was diagnosed, and she was operated. And I saw the disease and the impact of acromegaly directly in a family member. And I think that changed a bit your perspective. But again, for a patient that is newly diagnosed, reach out to other patients, uh, get the right information, and make sure you are in the right hands with your endocrinologist and with your surgeon. Those are very important decisions. Who treats you medically, surgically, makes the diagnosis, who takes care of you is extremely important. There is a wide difference, especially I would say in the surgical techniques, and it's so important to make the right decision. So be informed and get support from those around you.
Specifically for acromegaly treatment, from your experience, what gives you the most optimism about the future of it? Or is there any?
Yeah, I'm very optimistic because we've seen. So listen, but from when I started doing endoscopic techniques in 2009-10, that's when I started really doing it myself at a high level. At that time, on those first initial years, remission rates for acromegaly were around 50%, all across the board from the majority of surgeons. Our own techniques, and we were very advanced at that point with Indonesian techniques, were about 50, 60%. And we were puzzled why they were not better. And we understood and we learned that it's this invasiveness of that wall of the cavernous sinus that explains a lot of the remaining disease. So we studied the anatomy of the wall. We studied the technique on how to remove it. And the remission rates improved gradually. Then we understood that this tumor was going to the cavernous sinus. We understood the different compartments within the cavernous sinus, how to deal with each different area within the cavernous sinus to remove tumor from there, the risks, the benefits, how to do it. And we kept improving. So we went from 50, 60% remission rate to above 90%. So that is an amazing improvement. Now, the motivation is to get that remaining 10% or 20% that are not in full remission, the best possible outcomes. And I think we're getting there by improving a bit of techniques, and radiation techniques are getting better. A very exciting technique we are developing now is better imaging. A challenge for these 10% or so of patients that are not in remission is making sure, understanding well what is the tumor, where is the disease. We've done a great operation, but we still don't know what's happening by when the patient is not in remission. So, or is got an operation somewhere else, and we're not sure whether it's tumor here or there. So there is something called a PET-MRI. It's a type of functional MRI study. They inject a tracer, and that tracer specifically goes to the cells of functional pituitary tumors. And this imaging technique can actually show very nicely where is that residual tumor. I'm saying potentially because this is a technique that it is understudied, underutilized, and we are doing more and more patients, and we're doing more and more. And I'm very excited because we are seeing excellent results. And I think this is going to be a game changer for acromegaly patients that have persistent disease. It's going to help us identify where the small tumor is, and based on that, make a determination of whether another operation is the way to go, or radiation tailored to that specific area is the next best step. So I think this is going to help the patients. Ultimately, also medical treatments are evolving. And although that is not my field of expertise, for that, I rely on my great endocrinology colleagues. There are new drugs that are being developed that are more convenient. There are oral forms as opposed to injectable forms that are less convenient. They're probably improving on the side effects and being more efficacious. So there is definitely progression in there also.
Game-changing techniques are exactly what people like myself living with acromegaly need, Dr. JFM.
Yes.
Thank you. We appreciate it. As someone living with acromegaly, what I've learned is knowledge is power. I've tried to become an expert of acromegaly and how my body reacts to it. Dr. JFM, what empowers you to keep doing this work? Why do you keep going?
I keep going because I see that our patients are still in need. We can help many patients, but there are some that their disease is more invasive, is more difficult, and we still cannot fully remove the tumor or get remission on these patients. So that is the motivation. The motivation is we need to keep getting better, and we try to improve, and we would like to reach 100% of remission rate. We know that is not possible, probably because almost nothing is 100%, but we want to reach 99.9% of remission rate in our patient population. So that's what motivates us. And we want to do that at the minimum risk. We want to do it with techniques that have very little risk for our patients, that do not have any permanent sequelae in our patients, and making as convenient as possible. Now, there is always a price or a sacrifice to pay for. When you go for surgery, it's not fun. You need recovery. You need to take some risks. Your body changes because you need, your nasal cavity needs to be open, etc. We're trying to make that the least invasive possible and the most effective possible.
Sounds good. And you talk about recovery time. Again, I'm a guy who had pituitary surgery, and honestly, I did everything wrong after surgery. What are some realistic expectations patients should have about the first weeks or months after having pituitary surgery?
Well, the general rule I tell our patients is, it goes in stages, right? There is the acute stage of surgery, which is the first few days. Those are definitely the worst. When the pain is the highest, the discomfort is the highest, the risks also are the highest. The risk of CSF leak, issue with your sodium levels, et cetera, et cetera. That you spend the first 1-2 days in the hospital, then it's the first 2 weeks that are rough. Then there is the second stage, which is from the first 2 weeks to approximately 6 weeks, that month after the first 2 weeks, where you're gradually getting better and gradually getting to baseline, but you're not fully there. I recommend all patients to take 6 weeks off minimum after an operation like this. I know some patients need longer, and it all depends on how you feel. Some patients are actually feeling really well at 2 weeks. Some patients still do not feel really well at 3 months. It depends on a number of factors. Depends on whether everything went great with surgery or there were some issues with, any potential complications. What was the overall health of the patient before the operation? What was the overall impact of acromegaly? Was it mild? Was it severe? All those are important factors that play into your recovery. But minimum 6 weeks. If I see a case that is more involved, more extensive, I might say maybe you're going to need 3 months to recover. You have the luxury of taking the time off. Please plan accordingly so you can recover properly before, going back to your normal activities.
Understood. I did everything wrong. I went back to work way too soon. Thankfully, I didn't have any problems with what I did. I didn't have any CF leaks, and everything worked out for me.
Good.
You do a lot of surgeries. How many in total do you know off the top of your head have you done, and how many did you do last year roughly?
Well, I'm a very specialized surgeon. I just do operations on the head. I don't do any spine operations, for example. And actually within the head, I mostly do operations. 95% plus of my operations are on the base of the skull. And I do approximately 350 a year. And roughly 2/3 are endoscopic endonasal operations. So which means I do about 200 or a bit more operations through the nose, endoscopic endonasal operations a year, of which about half of them are pituitary tumors. So I do about 100 or 120 pituitary tumors a year. And I've done in my career close to 2,000 of them. And yeah, the numbers keep increasing. For acromegaly specifically, in the last 5 years, we've done 100 and I think 20 cases we are reaching now, which is probably more than any other institution in the United States, I believe, although I'm not 100% sure. I think the only numbers that are comparable or higher for sure are in places like China, where they have tremendous volume. And their techniques are still evolving, but they're getting there.
Okay. Well, with that being said, my hope or my thought is people are being diagnosed at a higher rate right now than if you guys are doing the number of surgeries that you're doing, which is good for patients with acromegaly and people moving forward being diagnosed. Hopefully that means that people like myself and the acromegaly community, what we're doing is working as far as building awareness and getting people earlier diagnosis is what I would think, which is exactly what we're trying to do.
Exactly. And the job you're doing, your podcast, it is an important way to raise awareness. And absolutely, early diagnosis in acromegaly and as in other diseases is critically important.
Dr. JFM, thanks on behalf of patients like me and so many others. Also, thank you for your time. Thank you for being here. And thank you for talking acromegaly with Tony. It's been an absolute pleasure.
Tony, great to talk to you. And congratulations on the great job you are doing. Keep going. We'll be here to help if needed. Thank you very much.
Absolutely. Thank you very much. And I'll close with this. Dr. JFM, one final thanks for sharing your expertise, your heart with our community. Conversations like this remind us that behind every diagnosis is a person, and behind every successful outcome is a team that truly listens. To everyone watching and listening, keep asking questions, keep advocating for yourself, and know that you are not alone. If you found interest in this episode, drop a comment, share it, like it, hit that subscribe button. You can also follow me on all my social media platforms. Until the next time, take care of yourself, take care of each other, and never stop believing that better days are possible.